This episode of Conversational HUGS with Lynne Michelle is proudly sponsored by Fox Chase Cancer Center.
Hugs! Welcome to another episode of Conversational Hugs with Lynne Michelle. I am your host, Lynne Michelle, and we are here at Fox Chase for another incredible conversation with Kathy Henderson, Nurse Practitioner at Fox Chase Cancer Center. Kathy, can I call you Kathy?
Yes, you can.
Listen, I want you to introduce yourself and tell the audience what you do at Fox Chase.
Absolutely. Thank you for having me. I'm Kathy Henderson, a nurse practitioner in our genetics and risk assessment program. I see women every week in our high-risk breast clinic who have an increased risk for breast cancer, either by having a family history of breast cancer, close relatives with breast cancer, like your mom, sister, daughter, aunts. Also, I see women who have a genetic mutation that can increase breast cancer risk. The highest risk and the most common that we hear about is the BRCA1 or the BRCA2 mutation, but we know that there are other genetic mutations that can increase a woman's breast cancer risk. And then also we know that a woman has personal factors that can increase her breast cancer risk. And so I see women every week here. We can use risk models, calculators to try to calculate a woman's lifetime breast cancer risk. We know that unfortunately all women have about a 12% chance of getting breast cancer over their lifetime, and that's the average risk woman. But when we do these risk models and calculators that factor in a woman's personal factors, her family history of breast cancer, and then if a woman has a genetic mutation, what we can do is we can then talk about what breast screening is right for you. And a lot of times, these high-risk women, we can do more than a mammogram once a year. We can add to the annual mammogram. And I tend to see my women here every 6 months. And we do breast screening every 6 months with an exam and with breast imaging.
How does the patient, how does she get labeled high risk? What test or how does she get referred to your high risk department?
Right, and that's a great question. And a lot of the referrals. They can either be established patients already here, or a lot of time the gynecologist in the community. It's always important for all of us to discuss our family history, really of all cancers, with our medical providers, and any updates. Unfortunately, we never want there to be new cancer diagnoses in our family, but when that happens, it's important to update our family care doctor or our gynecologist. And if we find that there are breast cancers in one or more close relatives, then that can certainly refer a woman in to meet with us. Again, family history is one piece. We know that personal factors can also contribute. And then the genetic mutations, we know that only about 10% of all cancers, meaning 10% of all breast cancers, are caused by a genetic mutation that someone was born with, like a BRCA mutation that someone inherited from their mom or their dad, because these genetic mutations can be inherited from our dads also. And so again, if only 10% of all breast cancers are caused by a genetic mutation, well, then that means there are other factors, right? Lifestyle, environment, personal factors, family history. And so, a lot of times maybe it's the woman who really wants that information, and she says, I want to come in and I want to get my lifetime breast cancer risk score calculated.
Gotcha. So you said something that was very interesting. So I'm in my PCP office, right? And I am just there for my checkup. But my mother, my auntie, was diagnosed within the last year of me coming for my annual testing at my PCP with some type of cancer. So if I hear you correctly, I should share that information with my PCP if it's a close relative. Like, oh, and by the way, my mother was diagnosed with breast cancer. And that's how they gather the information, and that's how referrals can take place. Did I understand that correctly?
Yes, that is right. Yes.
Okay. And it's not like you're snitching or telling, but you're sharing to help you be proactive in your health care.
Absolutely.
Okay.
Absolutely.
Okay.
And, part of what we do in our risk assessment program is we not only want to care for the woman in front of us, but we want to care for the family.
I love that.
And so at every visit that I have and that everyone in our group has, when a woman comes in and I see her every 6 months for her breast exam and her breast imaging, we look at the family tree, which you'll see an example of later. And we make sure that all the family members are being addressed. And a lot of times we can identify then a sister, an aunt, someone who can come in for either genetic testing
Nice.
or to have more breast cancer screening. And so, we always want to make sure that we're obviously addressing, the woman in front of us, but that the family is being cared
entire
for.
family. I love that. You said something that was huge and definitely different from the time that I took my genetic test. The word came back where my father's side did not matter. It was always leaning towards the maternal side, right? And I was like, well, wait a minute, 50% of my gene pool comes from my dad. And the cancers were tilting heavily on that side. His sister, great uncle, prostate cancer. And so my mom's side, they were good to go. And I walked away being told that my cancer, triple negative, was environmental. And so in my head, environmental, okay, I'm not eating nothing. And so I actually went into a tailspin going through treatment because I stopped eating certain things. They was like, no, do not change what you're doing while going through treatment. You need
Right.
that iron and you need all of those different things. But I'm glad to see that both sides are included now, because
And I think that is a misconception.
it is.
And not to keep using BRCA1 mutation as an example, but we know that is our highest genetic risk for breast cancer. But we know that there are about 13 total gene mutations that can increase a woman's breast cancer risk. And so prior to 2014, we were only testing for BRCA1 and BRCA2. But
Wow.
after 2014, we now can test for the full 13 genes that can increase breast cancer risk, but also even larger panels, panels of either 48 cancer genes or even up to 100 genes. But back to what you were saying is absolutely right. A BRCA mutation can come from a woman's mother or father. And because we know that the greatest cancer risks in BRCA mutations are in women, sometimes if a BRCA mutation is being inherited from a woman's father, we may not see a lot, and if there are more men on that side of the family, it may not look like the BRCA mutation came from dad, because men don't have as high of a cancer risk with a BRCA mutation as women do. And the other thing I wanted to mention is, just like what I mentioned before is, all women have about 12% chance of getting breast cancer over our lifetime. It is, the female cancer with the highest risk. When we see women in our risk assessment program, we can do these risk calculators. And if we ever identify a woman whose lifetime breast cancer risk is 20% or higher, then we can do more than a mammogram once a year. And then that woman can be followed in more of a high-risk fashion if a woman's breast cancer risk is 20% or higher. And that number can change over time.
Okay.
As we get older, as things change in our family history, as things change in a woman's personal history. So when I see women over, many, many years, we may recalculate that risk model to see, has that number changed? But, breast density is another big topic that has gotten a lot of attention in the last couple years. We know that breast density is a risk factor for breast cancer. We know that now every time a woman gets a mammogram, which again, every woman starting at the age of 40 should have a mammogram every year, but every time a woman gets a mammogram now, it is required that your breast density is on that mammogram report. And you should have a discussion with whichever doctor ordered your mammogram. What is my breast density? Is my breast very dense? Based on breast density alone, even if a woman doesn't have female relatives with breast cancer, a woman could potentially get more screening than in addition to a mammogram just by having dense breasts. And so your mammogram report will say that, and it's definitely a conversation that you want to have about breast density.
I just had that conversation with my cousin who lives in D.C., who called and actually texted and said, Lynn, I just had my mammogram and they want me to come in. What's going on? And I said, well, slow down. Ask some questions. First, did you have a 3D mammogram? You have dense breasts. She's my cousin. I know. And so,
and most young women, are going to have dense breast tissue, right?
And so I said, density is the key, and they wanted to have an ultrasound and something, ultrasound and a scan. She was saying, but now she knows. And so just having that conversation, because we just say we got big boobs, right? But
the size does not correlate with the density. Right.
Correct.
Right.
So that's good. Yeah. I had a reduction in a lift, so so I'm not as dense, but that is important. That is definitely important.
It's important information to know.
But just having that density is my breast, and do I have? So that's a good conversation to have.
Right.
So thank you for that. That's a great nugget.
And breast density, again, it's on every time you get a mammogram. It's A, B, C, or D. A is completely fatty. C and D is very dense. If you are C or D, you could potentially get more screening just based on the breast density alone.
That's good information.
Okay, and so it's good knowledge for a woman to have and for a woman to understand when she gets her mammogram. Typically over time, a woman should become less only the mammogram will tell. Only the mammogram can tell.
Losing muscle mass. How do we get less dense over time?
I think it's it tends to be the hormonal factor.
Okay.
And so typically as women get older, they kind of move away from being more dense towards more fatty.
So I love the fact that you said 40. I have
for average risk women.
Average risk women. Okay, that makes sense. Nikki, who mother passed away from breast cancer, she had her tests done and she was at a 30% score of getting breast cancer, and so she had to start her screenings early.
And and so that's why if a woman has a close female relative, a mom, a sister, a daughter, who has had breast cancer at a young age, we have this 10-year rule.
Yes.
Meaning screening can start 10 years prior to the age that close relative was diagnosed. So let's say someone's mother was diagnosed with breast cancer at 45. Then her daughter can start mammograms at 35, which is younger than all women starting at 40.
At 40.
So there are situations where mammograms can be started earlier. Now, a mammogram is radiation. Typically, mammograms are not done under the age of 30, especially because mammograms are radiation. But if a young woman under 30 needed some imaging, we can do an ultrasound. We can consider a breast MRI. Women with a BRCA mutation, they actually start breast MRIs at the age of 25 and mammograms at 30. So really the best advice I could give is, if you're ready for more information, if you have a question in your personal history, your family history, then sit down with a provider in a high-risk breast clinic or a genetic counselor.
I agree.
Because we have the knowledge and the expertise, we know the questions to ask, the information to gather, to know what your risk is, to know the care that we can provide for you, but also for the family.
That's an excellent way to end. And if you come to Fox Chase, we hope you do, you can always look for
Kathy Henderson.
Thanks again for
You're
joining us at
welcome.
Conversational
Thank you for having
Hugs.
me.